Good morning. How's everybody? Oh, God, that was pretty pathetic. Well, first of all, let me just say, yeah, good morning.
Good morning.
Whew, thank you. Well, first of all, let me thank you and tell you how awesome it is to be here. Dr. Mordecai's kind words. It's made me think, and I know that we're going to get into some content that I want, but it made me think about the perceptions and the idea about this concept of ensuring that, mental health and physical health are integrated. And I think that one of the things that my new agency is really focusing on is that we have to sort of stop those distinctions, because mental health is actually a completely part of our health. And so when we think health, we need to get the public and others to start understanding that health actually includes mental health, and it's not on the outside looking in. And that's one of the big things. And then secondly, is that mental illness, and this is a critical piece that I think has helped me at least frame some of my thinking and comments, but mental illness is a pediatric illness. And I let that sit for a moment. And what really is meant by that is that the studies are pretty clear that by the age of 24, that all mental illnesses that adults have that can be are identified and manifest themselves by the age of 24. 75% are manifested by the age of 24, which really does mean that mental illness in so many ways relates back to childhood and these issues. And so for us and for what we're trying to accomplish, I think that it's really critical that we begin to really push on the perspective and change the conversation, making mental health part of health, and making sure that folks understand that waiting until we're adults is too late. And because mental illness is literally a pediatric illness. I also have a big thing for child psychiatrists that in my view, it's time that child psychiatrists no longer become adult psychiatrists first and then have a 2-year fellowship. I think it should be the other way around. I think everybody should become a child psychiatrist first, and then they specialize in adults. Because isn't that awesome? Yeah, that made me real popular at the American Academy. So anyway, another thing is that, whenever my remarks are today, my hope and my goal, every time I, get in front of an audience, really it's a privilege to do that, is to push. I saw inspire, whatnot, but to take home, think about what is the actionable strategy that you can take home. I mean, it may not even be from my presentation. That's okay, because so many people here are really smart. It may be from something else, but what can I do, to really take things home? And I think that's really important. And also, I know that folks were asked to put their cell phones on silent or something. I actually prefer ringtones such as Led Zeppelin or, anyway, just a little amusement. I did want to share briefly that as it was shared, literally within the last month and a half, I have left SAMHSA after 15 years and 10 years with the state of Connecticut, so 25-year government career. Time to move on, folks. And as this, I just can't believe how fortunate I am to be able to work for the Meadows Mental Health Policy Institute and really help to create the next iteration of what the Hackett Center is going to be. The Hackett Center for Mental Health is called that because, Jim and Maureen Hackett are passionate advocates around issues of mental health because of their own family, and have been very lucky in life, and so have money and gave a $20 million gift to establish the Hackett Center. So it's really unusual to be an executive director that walks into a place that has already an endowment. So I'm very pleased about that. And let me tell you, if any of you out there are interested in creating your own center and have an extra $20 million around, I'm happy to name something after you. So no worries there. I also want to say thank you to our Meadows colleagues and the Kaiser for allowing several of our my Meadows colleagues to be here today. Really, what drew me to this job and to come to Texas, move to Houston, was the brilliance and the passion and dedication of our Meadows staff. They're really awesome. They also have a lot of ground level work activity. I see Linda Rodriguez in the room, who's done all of this work at the ground level, and I really am going to encourage folks to talk to folks like Linda, because we're proud of this work and proud of our work in doing this. I mentioned, my giving props to Jim and Maureen Hackett for their inspiration to create the Hackett Center. They will speak eloquently about their family's own personal issues around mental health. This is not a surprise that mental illness transcends socioeconomic class, race, geography, ethnicity. And so by them really allowing the community to understand what it has been in order to get them to this point that they wanted to give a sizable gift, substantial amount of money to create an entity that focuses on better policy. So the idea of moving good policy into practice is all about what Jim and Maureen Hackett are all about. So that's sort of where I stand. I also want to really make sure I give special props. There's not enough young people in the room because otherwise you would have gone, oh, wow, he's so cool. Special props and thanks to my colleagues at the Substance Abuse and Mental Health Services Administration, having worked there in the last 15 years. I love SAMHSA. I love the mission. And the people that there are incredibly dedicated, and particularly Lark Wong and Mary Blake and Becky Flato, because honestly, they helped actually create this entire PowerPoint presentation. So it was very appreciative. And they're the smart ones that are doing this. So for me, what I really want to focus on today in my time with you is a quick understanding and definition and sort of for us to come together about trauma. Learning the 3 E's. Are you all familiar with the 3 E's in trauma? That's good. They got 2 people. But what does that mean? Certainly the developmental impact of trauma, a little bit about ACEs because I think most people know, but also then some examples from our field. And so that you can return home with resources. There's an entire section at the end that I will not get to today. However, it has links, it has information and follow-up materials for anyone out there that was taken by any of the things that were said here, either by Sharon or Don, myself, or all the panels that are to come, so that you're really ready to go home with that kind of information. And don't forget that the Meadows Mental Health Policy Institute is here in Texas to help folks. Just yesterday, we sent out this huge email blast. So if you're not getting the email blasts, please do, because the email blast talked about a brand new $20 million investment that the Health and Human Services Commission, HHSC, here in Texas, has just put out a funding announcement for community-based organizations to do good mental health work, part of what was historically passing legislation a couple of years ago, Senator Ford Price, I believe, and others. So those kinds of things are interesting. So that's sort of my goal and hope for today. So really we're going to start with defining and understanding a little bit of trauma. And again, I will breeze through some of this, but hopefully they'll make slides available. And also you'll see my contact information at the end if anybody wants to follow up or get further information. The important thing for us to start with is this idea of that individual trauma results from an event. So you're thinking about these E's, or a series of events or circumstances that is experienced by a person as physically or emotionally harmful, threatening in some way, that has lasting effects. So event, experience, effects. And that's really the key to what some of the things that we'll actually want to discuss going forward, because that is so critical. Because people, I practiced clinically for many, many years, and folks had said to me, well, gee, this one young person, it seems to be doing really well, but and had all of these things happen, 5, adverse experiences, but yet this other individual may have only had 1 or 2, but really seems to be struggling. And what is that about? And I will take that back to this idea that trauma is really a personalized experience. That these are the things that have to understand, that it just because somebody says, oh well, that wasn't as big of an event. Please don't think about it that way. Think about it as the perception from that individual. That's really key to me. The other piece to this, in terms of important considerations, is that when we started to think about trauma years ago, people wanted to know, well, what's wrong? What's wrong? And there's been a lot of that kind of conversation clinically. And I used to do some training around this, and that's really a typical thing. Whether you're a clinician, a teacher, or a staff in a school, wherever you are, in a child care facility, et cetera, folks are really focused on the wrong part. It's the way we've been socialized. That's what the doctors do when you go. What's the matter with you? So people do this all the time. And we're trying to shift the conversation from thinking about it as that problem, what's wrong, as to what happened to you. And so when behaviors are coming out, instead of like, what's wrong? It's what happened? And that sort of dialogue has really helped people to engage more conversationally about some of these things. The other piece I think it's really important to consider is this idea about symptomatology, and that, that people will get upset at behavioral issues or emotional kinds of things that happen in the wake of trauma. And really, I think a lot of times what we can say is that these behaviors and that these emotional outbursts or whatnot are really adaptations to these kinds of traumatic events. And that adaptation is really important to understand. And then finally, that healing happens in relationships. I think, both Sharon and Don sort of alluded to sort of this, that the resilience piece to the puzzle of all of this is about relationships. And it's the relationships that we form, and it doesn't have to be clinical relationships. It can clearly be relationships that are formed in families. My historical work has been creating systems of care across the country, these little pockets of excellence where everybody's collaborating and working together. And the real goal of all that is that, whether it's the coach, the probation officer, the teacher, the lunch lady, the maintenance worker, really relationships can form at all levels. And that's what we have to do. Trauma-informed schools, trauma-informed settings and organizations really think about this as a way that every person that's part of this team, that's part of our system of care, can build the relationship necessary. I love the slide that Sharon used that talked about the math teacher and how that math teacher saved her life. Well, there are many, many math teachers out there. There are many, many child care specialists out there that can do the same thing on a day-to-day basis. So that's it. As we're going forward, it is really also critical to understand that our bodies respond between the idea of our biochemical reactions and things, that trauma events or any event that we perceive as potentially trauma, and that can be a range of things, impacts our amygdala. And in the brain, the very sort of primitive ways of doing things, it really gives rise to this idea of this, flight, fight, and freeze responses. And that's really what our brain functioning, and our brains adapt to these things. That's why, we are very much controlled. That's why a lot of things that I talk about now involve brain health. Because it's about our brains, folks, and it's the interaction of our brains and our environments that are making all of this happen. So when folks start thinking about this as a brain adaptation, it actually helps. I have a very good friend who does massive amounts of training in correctional facilities. She was the director of our National Building Bridges initiative to help residential facilities do best practice. And what she was doing was she was bringing the brain science to correctional officers to help them understand that it wasn't that this person who's in prison, who's been convicted, etc., was trying to be bad on purpose, that it is actually a response, a brain response. And that's what was happening. In residential facilities, I have this long story about this little 8-year-old who was sitting there flicking the light on and off. Have anybody ever had the lights flick on and off? You want to start doing that now? Kind of is annoying, right? So rather than sort of understanding that this young man was probably reacting to some trigger that had happened, the child care staff at that time actually decided that they would stop him from doing this terrible behavior, grabs him. Of course, what did that end up in? A restraint with a broken arm. And my agency had to substantiate abuse and neglect on this because it was totally unnecessary. So I say all of this because the correctional officers that went through this brain training about trauma completely changed the way they were thinking about their wards. And that is a huge deal. So is it really a problem, or is it an adaptation? Is it that we're talking about somebody who's non-compliant or combative, or are they struggling to regain the power that they've lost because of the event that's been happening to them? Are they treatment resistant and uncooperative, or are they simply withdrawn because they don't want to have anybody involved with their lives? So again, the idea of fight, flight, or freeze, that somebody who ends up being passive and unmotivated may simply be just giving in. And that's not good either. right? So we might feel better about it because, okay, this child's not giving us a hard time, but maybe their passivity and their not being motivated or withdrawing actually is a sign about what happened to them, not what's wrong. What happened to them? So that's the thing. So there's a bottom line to all of this, and I think this resonates with me, and it comes from my friend Lark Wong, who is a senior advisor at SAMHSA and a mentor and somebody who said that all of these things taken together, the reality is that when kids are too sad or too mad, they can't add. And that to me really is, and so I'm making sure that Lark gets props for this. And then it also says that all children and youth are more prevalent, ACEs affect more children and youth for children of color living in poverty, families with lower education levels. So that slide was meant to go under the actual ACEs slide, but boy, isn't that accurate? When you think about it, that's a very important thing. All right. So now we're going to shift gears and talk a little bit about those 3 E's and what it's sort of framing for all of us to do. No, let's think about it. Again, as a quick review, the events, the circumstances that give rise to trauma, the experiences, which is that experience that determines whether or not this is a traumatic event. Again, what's a traumatic event for one may not be a traumatic event for another. And it doesn't necessarily mean, that this was so horrible versus this wasn't really so bad, because something that you might think isn't so bad can be really perceived that way. And I say that many times because I think that's been a real issue for us in the clinical world, which is that we try to pigeonhole folks into these little boxes and saying, well, that didn't give rise to the level of, major abuse or something. But you know what? It really impacted that young person. So that's the thing. And so what are the effects and the ultimate effects of trauma? And Don said it really well about the idea that trauma has adverse experiences as those behaviors are coming out in all different realms, social, emotional, and I think, interestingly, of course, physical health. And that, to me, has been a really important way for us to start to describe the connection between physical and mental health, is that they're completely intertwined. People that are depressed are so much more likely to have cardiovascular disease. And it's just the reality. And people who have diabetes are much more likely to be depressed. So you can't really, take out one from the other. When Descartes, you guys remember that? When he talked about, mind, body kinds of things, that is true. So wait, we learned this thousands of years ago. So what is our problem today? I don't know. But in reality, so the 3 E's are things to think about. And then we have to think about what are, quote, potentially traumatic events. Now, there are a lot of potentially traumatic events that come from things like abuse. I mean, clearly emotional, physical, sexual abuse can give rise to us thinking about this being a traumatic event. And at the same time, so can, being involved in domestic violence or even witnessing violence. And you think about some of our communities across the country. I had the opportunity to walk into a show the other day. Oh, Kelly Clarkson. Yay, Texan, right? Some of us may not have been born here, but we got here as fast as we could. But Kelly was born here, and really she was trying to focus on all of the different things in the schools. She was going out into schools and looking at these different kinds of traumatic events. And the one thing that was being stated was that they were building this garden, and across the street was this barren area of railroad tracks and potential areas where there's been shootings, et cetera, and then there's a garden. And the young people that have been witnessing those kinds of things and have that in their own neighborhoods, imagine having to grow up in those kinds of neighborhoods. And that can, witnessing that is true. And nowadays, with our online presence, we have opportunities for bullying to the nth degree, because we can do it online. And you've even heard of folks who talk about how, they're online bullying or, you should just kill yourself. And actually it happens. We have to be cognizant of all of these things. Loss, of course, is another area that we focus on in terms of trauma. Here in Texas, as well as right now, the California wildfires. I mean, think about the loss from and experiences from natural disasters. You know, in Hurricane Harvey, post-Hurricane Harvey, while I wasn't there, that was one of the reasons that the Hackett Center was born, because Maureen Hackett was just devastated by the amount of trauma that occurred from the loss of not only life, but property, and having to move, and being displaced, and losing your friends. I mean, all of these things are traumatic events for folks. And now we have things like terrorism and school shootings. I mean, the things that are things that we have to worry about, that my grandchildren are now having to worry about, which is just unbelievable to me. And of course, chronic stressors, whether they be racism or institutional racism kinds of things, or historical trauma, and things that happen within families, like children growing up in families with significant substance abuse issues. You think today, I know the opioid crisis has really risen and has been given a lot of funding and stuff. I also would tell you that while that is important, do not lose sight of the meth crisis back in this country. Okay, and so crystal meth is alive and well and expanding across the country again, and we need to be very worried about this, because the impact on children and on other in terms of trauma and traumatic experiences is huge. So homelessness, all of these are examples, and one that didn't actually make the list for this, but I began to think about as pulling this presentation together. One of my first experiences as a fledgling intern clinician, as a psychologist, was none of these. I mean, I was working with children, doing groups for young people that had been sexually abused, physically abused, doing all this. The thing that changed my life, I think, was going into a child care center. Some of you call them daycare centers. I don't, because we actually care for children and not days. Just a personal thing. So in a child care center that had a pit bull. No, not the guy who's a rapper. Our actual pit bull leapt over the fence and bit two of the children severely at the child care center. The trauma experiences. So we went in and did a crisis in a debriefing approach. We dealt with parents. We had people come in. These were young children. So how are we addressing all of this? Interestingly enough, over the 3 months or so that we did, and we probably should have stayed. This was a long time ago. Remember, I was an intern. I was a few years before now, and what we, I think, learned more was that over the course of that time, most of the kids were doing pretty well with the services and supports and parental reassurance. And this was stated before, the folks that were not doing really well, the teachers. And that became really something that was really, challenging and scary. So again, the event is very important for us to understand, putting it into context. The experience as well, how, when, where, how often, those are also things to consider as part of this. We've heard terrible stories of ongoing abuse, ongoing neglect, literal threats to for bodily harm, but also interventions and the resilience factors. Again, Don mentioned it before. We know that having one caring adult in that child's life who's is consistent, creates continuity, and is able to have congruence, or be, the adult that's very helpful, can also be capable of mitigating some of the traumatic events to a point where young people can do better. So those are the things that I wanted to make sure that we continue to think about going forward as you're talking more about specific programs and issues. So the effects of trauma, also remembering that that there can be long-term effects impacting our psychological as well as our physical and spiritual activities. And in terms of some of these signs, again, you can see this, and I don't have to go over all of them very clearly. We know when a child is blowing up, or when they're resisting, or just being self-destructive, or childlike when they should be, acting, sort of reverting to younger behaviors, or their nightmares and sleep, kinds of issues, emotional swings, psychological. Again, it's not what's wrong, it's what happened. can you tell me more about what's happened, that's giving, essentially giving rise to these different kinds of behaviors? And so it takes it away, hopefully again, taking it away from the child feeling that they're being blamed for something, that simply they're reacting and engaging with the world because their brains have been so impacted and their amygdala is very triggered, okay? So all of those things are important to remember. Now, another thing that I was asked to do, well, here's some more signs. As I put that up, another thing that I was asked to sort of talk about was the ACEs study and the impact that we know of trauma on ACEs. And it's really interesting. HRSA, you just mentioned that, that Kaiser's doing this sort of re-study and doing more. I'm so excited, and you guys are awesome. And if you were at one of my other places, they would have had a big dinosaur picture with Don's face up here because he's like an awesomeosaurus, for doing all of this work. But the National Survey of Children's Health through the Centers for Disease Control has actually just, through HRSA, has just published data and came out with a press release in October saying that of all children across the country, that at least more than a third, have had even just one traumatic experience. And that when you start looking at our populations, particularly the young people that I've served in my career that have, quote, serious emotional disturbances, upwards of 80% have at least several ACEs or more. And that's huge when you start to think about the cumulative effect, because the impact of trauma really is cumulative. It just doesn't stop. And so if you have more and more ACEs added onto you, it's going to affect you more and more. It's going to make that potential for, cardiac condition or a heart attack, more. And that, again, it affects the developing brain, and it increases the likelihood for negative health behaviors, which we know are one thing that we can not only treat, but could avoid untimely deaths. And so whether it's because people drink more, smoke more, eat more, that trauma histories give rise to a lot of that. So those are really important. And as we're going forward here, the ACEs study really is the benchmark for all of what I think we've learned and then expanded on this learning. Folletti and his colleagues, all of this stuff really did. And again, the idea of a linear relationship between the number of traumatic experiences and negative outcomes, I think was perhaps hypothesized, however, not contemplated as much as it really has impacted the field. That literally the more ACEs you have, the poorer your outcomes are going to be. And I think that's really it. So I distilled some of this, and my colleagues, again, at SAMHSA from the National Center of Trauma-Informed Care and have put this just together to really remind us that the negative outcomes over the course of the number of traumas continues to escalate. This is a big deal because, when you look at people that are experience depression or using drugs or attempted suicide, traumatic experiences, adverse experiences, and I would even argue that adverse experience kind of things probably should be even broadened to some of these other categories like natural disasters and other kinds of things. So those are critical components of all of this, and all of that gives rise to much more negative outcomes and going forward. The other thing that I am really struck with is that the also indicators of impaired worker performance. I mean, basically, the reality is higher number of ACEs, higher absenteeism, higher problems with finances, and serious job problems. Our employers, one of the things that I'm really excited about getting into is work with our employers, and this is the kind of thing that they need to understand, because you're going to have more problems, and rather than the first step, which is like, you're going to get on a performance improvement plan, or what happened to you? I mean, I think that a caring approach to this is really the way that we go. So that's sort of the way we think about it, I think about it, and we know that reported prevalence of the trauma experiences in behavioral health is huge. Like I said, over 80% of the kids that were in our systems of care had multiple traumatic events. We know that 2/3 of adults in substance abuse disorder treatment had reported child abuse or neglect. I mean, 2/3. 2/3 of them had sort of reported these sort of things. So SAMHSA data has been able to do that as well. And we know, and that I know it's really cool that we've got some people in the room from early childhood all the way through, through kindergarten and elementary and middle and even high school. Age-related responses are really critical. Again, this is in your packet, so I'll just breeze through a little bit. But very young children, their responses to trauma are going to be different than your teenagers. Now, some of them are the same. I mean, I don't know about you, but I was a teenager. Sleep disturbances seem to be part of life. But when they're a real baby, trying to address sleep disturbance, trying to address things around attachment issues versus, your school age or your teenagers who are potentially really focusing in on relationship issues and having problems with self-regulation and stuff. So what we have to do, and what I think the field has done is really good, is to come up with age-related responses so that depending on, your developmental component, your age, that we need to think about interventions from that lens. So when you're really young, trying to get a sleep cycle back into the right sort of, well, if you're a parent of a newborn, you'll understand this. But those are important things, and the different kinds of therapies that are offered. But again, for teenagers, it may have a lot to do with creating safe spaces, with developing those relationships, because again, healing happens in relationships. And as part of that, what we do know is that when we're thinking about investing in responses to trauma, that we should be thinking, as we had the 3 E's, now we have the 4 R's. And the first one is that we have to be able to realize and understand the impact of trauma and the potential path for recovery. So the idea of the first R is that we have to bring realization to our organizations, our schools, our communities, about what this is about and about the brain health, etc. The next thing, again, is that we have to be recognizing that the signs and symptoms and that behavioral outbursts or withdrawing behaviors, that it may be a sign of something else. And recognizing this is really critical. And how do we teach people how to do that? Well, there's a bunch of, programs that we heard about, from Sharon and others that we can do this. Respond. Again, fully integrating this idea of knowledge into the policies, into the procedures. How do you create a trauma-informed school, a trauma-informed organization? We have data and do this. And finally, we resist re-traumatization. This is a piece to me that was happening in our residential facilities, that kids came in traumatized with varying levels of ACE scores. And what do? We tried to get them to conform into behavioral issues, and when they didn't, we restrained them. Or we took away their chance to go home, or things like that. What does that do? It re-traumatizes. We have to resist and stop re-traumatizing people from doing that. And again, I think that is a real critical piece to it. And then finally, I think that we, just in terms of some examples from the field, I'm really proud of the work that the Meadows Mental Health Policy Institute and the Hackett Center has done, to address some of these things. One of them, and we have people here in the room, Lisa Tamako is all the way in the back. Just wave, and Linda Rodriguez, just do a quick wave. I do that because Lisa was instrumental, for example, in helping, I have it right here, create this trauma-informed report that talks about us being as part of the Texas State of Mind, which is a nice double entendre. But these are things that are available through the Meadows and through the Hackett Center around doing this. The mental and behavioral roadmap, the trauma-informed care project that I just mentioned with the commission, the mental and behavioral roadmap, we're going to be passing these little cards out to you. And these little cards on the back, if you take a picture of this, it will actually bring you to a major report, a roadmap and toolkit for how to address varying things in schools. And I think that this really is a special toolkit. Hard to get through the entire thing, but the modules are awesome. And again, a resource for folks. We've done a lot of work in supporting schools after Hurricane Harvey. Linda has been doing a lot of work in the Dickinson Independent School District around early childhood things. If folks are interested, please ask Linda about this. The work around in Pasadena Independent independent school district, we've brought the cognitive behavior interventions for trauma in schools, CBITS, into the schools, the Bounce Back program. Earlier, Sharon mentioned this idea of these mental health technology transfer centers, and they came out with this really kind of awesome, I'm not going to find it offhand, but a trauma-informed schools report that lists several of these prevention programs that I have all listed there. So these are things that we've been working on. And then finally, in the resource section, you're going to see in my slides about understanding staff trauma. This is so critical because ultimately it's about how we're handling our own issues and stuff. And don't forget about the concept of vicarious traumatization, because it happens. We talk about this with police, with firefighters. I will also talk about it with teachers and others who have gone through this, who may themselves have lost their own home during this flood, but are really out there trying to work with others. So these are huge kinds of a thing. And then this I really liked. These are tips to address staff. And then so you can do all of that. And then my last slide has to do with guidance domains for a trauma-informed approach. This is a literal checklist to talk about. It is not a one thing only. It is a whole environmental approach to dealing with trauma in your organization. Is your governance, is your policy, are there collaborations, are the trainings, are they putting finance into it, evaluation approaches? These are all things that I think we can do together. So basically, all of these resources are available to you. There I am. If you need anything in terms of this, please follow me on Twitter so I can get more Twitter followers than my own children, at Gary Blau, PhD, and my organization at Texas Mind, and our campaign, OK to Say. Thank you all, and let's have a great day.
Thank you. Thank you. You mind staying up here for a few seconds for questions?
Oh, sure.
So we have a little bit of time for some questions. And again, I'll point people to the microphones on either side of the room. But I'll just kick us off. I actually was really interested in what you were talking about in terms of the impaired worker, sort of worker performance as it relates to this. And I'm just curious if you could talk a little bit about what the Hackett Center might be doing to engage in that space or support employers to understand this about employees?
Sure. So I'm going to go back to sort of the understanding staff trauma and employer-employee issues. So one of the things, in fact, my boss today is in New York City with several large businesses talking about the importance of mental wellness and mental health services within businesses. And these are not, I mean, there are, whether you're a employer organization of 10 or 100 or 1,000 or 50,000, people should be mindful of this. And what folks are finding in the business community is that it is impacting bottom lines. And it's really interesting to me because a lot of businesses are doing this now, not because necessarily because it's a financial good thing for them, although it can be. They're actually doing it because they're caring about the employee and recruiting and retaining employees. And in this particular environment right now, we have to worry about that. So what we're trying to do is to create a way forward for all of these businesses to work together to think about ways that they can support their employees through wellness programs, through EAP programs, but it goes well beyond this. It's not just about doing a wellness thing. It's also about creating an environment that is healthier. So how many times, and maybe none of you have been through this, but you've worked for an organization, that sort of doesn't value the idea that, weekends are yours, or that when somebody gets in trouble, that they come down hard on people, and, there's like a sense of badgering or humiliation. Now, of course, I've never worked in a place like that before, so I don't know this, but apparently there may be one or two businesses out there. So how do you change the culture of the way that you're doing it? I saw on the news this morning that, I forget, one of the big companies is toying with the idea of going back to a 4-day work week. Now, in the government, I don't know if this is good or bad. I think that the proof will be in the evaluation. The government has had this for a long time. We called it alternative work schedules. I had staff that did 10 hours a day, or they did 9 hours a day and had every other Friday, So, but the idea, again, is that giving people an environment that's healthier. And so within that health comes better attendance, It also addresses issues with children, because one of the things that we have learned with children's health issues, be they mental or physical, is that parents take a lot of time off to have to deal with their own kids' issues. And in fact, in my world, some parents have literally lost their jobs or cannot work in order to deal with all of the physical or mental health issues. Systems of care, interestingly enough, and what we're pushing on by doing this through businesses, is that by supporting a family in that way, that we've actually saw within 6 months, 25% of the families that were not employed due to their child's health condition, 25% of them had been back to work full time. So that was a big deal for us. So businesses is a big thing, and I continue to harp on that. Our goal is to take these large companies and small companies and train them and teach them about all the possibilities that why health matters. And I think we got to keep doing that.
Great. Thank you.
Yeah. Yeah.
Any other questions?
Yes, ma'am.
Yeah. You mind using the microphone, please? Thank you.
Hi, thank you for being here. What are we doing for the state of Texas with our capital right down the road in regards to letting our highly trained school counselors who have high degrees and study very well in school, but yet they're not able to use those skills in the school setting because of testing and 504 and system support? It seems like it's a common thing that we can change through mandates to let us do our job and address the trauma in schools, and it could save us so much time and money if we just rewire our work. And what are we doing to advocate for these school counselors that want to be counselors and can't quite do it?
So first of all, thank you. That's an excellent question. And probably, many states, it's not just Texas, many states are struggling with, how to do this. I will say that in my short time in Texas, that one of the really awesome things that has happened, and, part of it comes from, tragedy, and out of tragedy comes opportunity. I say that, people say, well, geez, do we have to have tragedies to have opportunities? And I hope not. But if we don't seize on the tragedy to create an opportunity, then that's a shame on us, because we have to. So last legislative session, when Governor Abbott, for example, declared mental health as a priority and emergency legislation was passed, you see that in the last 2 years, I believe it's close to $600 million of new money has come into the field as a result. Now, it's not just education, but there's a lot of activities that have happened around the education issues, the trainings. I mentioned before about the work that Linda and colleagues have done to do mental health first aid and other to help to be extenders for your social workers who are so tied up in all of these things. Another thing that's happened is that in order to help the social workers is the expansion of the idea of using telehealth services for support. So there's there's a new program being rolled out around helping schools with telehealth support so that there's evaluations and assessments that can be done. Again, it frees up, hopefully, some time. I don't know how much of this is going to work in terms of complete freeing of time. What I do know is that having this as a backdrop, to have a school with the opportunity to be able to get online and see a mental health professional immediately or to do an assessment actually could be nation leading, if you ask me. And at the same time that's happened, that's called T-Chat, and Linda will remember the actual acronym for me. But at the same time that's happening in schools, more training, more addressing of trauma, expanding assessment and services that are available. The Child Psychiatry Access Network was also funded, and what that means is that we're going to be supporting local pediatricians where the most of the kids go when they first have an issue. They go to their pediatrician and they get anxious about, well, I don't know if I'm comfortable prescribing this medicine or doing this. And the Children's Psychiatric Access Network will allow them to get a consult from a child psychiatrist interest that's being put together through Baylor and through the University of Texas, and all of the things that we can do to demonstrate or to support a primary care doc so that the families don't have to go everywhere, that they can actually contain the care in their local community. So more telehealth services for schools, more ability for primary care providers to get consultation around psychiatry issues, and the funding of expanded funding that happened in Texas, I think is unprecedented across the country. So I know that there remain major challenges, and there will. I would just say that Texas has actually been a forefront in leading the way to show how these dollars can be used. And then just, the other, like 3 days ago, when HHSC issued the $20 million funding announcement that we've been tweeting about and trying to get the community-based organizations to connect with to do that. One thing that was interesting that I learned as I was part of the, sort of getting briefed on some of these things is that in Texas, some of the rural communities are having a hard time finding. Even though there were monies available to hire people like social workers and other licensed professional counselors, they weren't finding them. And so they were able to use those dollars to find ways to better interact with like local community mental health centers. So necessarily, it doesn't have to be hiring them in schools. It has to be collaborating and consulting with them. And so that's another sort of way, whether it's telehealth, agreements with local community mental health kinds of agencies, grassroots organizations that schools can do that will ultimately provide more services and supports for the students and families. So it's an excellent question, something to follow and something to be proud of despite the challenges that remain about what Texas has done to really push the envelope on getting money, services, supports out there into our communities.
Thank you. Well, will everyone help me please thank Dr. Blau for his presentation and for joining us today.
Thank you.
Thank you so much.